That's fine. Okay. Okay. Good
So,
evening.
good evening, sir. Good evening, everybody. And I'll just give a short introduction. So, we are discussing a very interesting topic today, which is artificial intelligence in cardiology. What are its future prospects and what are its pitfalls? A very exciting new concept in cardiology, and think something that we cannot get away from because it's going to come in a big way in cardiology. And we are fortunate enough to have with us Dr. Gurunath Parale, sir, who is the chairman of cardiology in Ashwini Hospital, Shorapur. And he will be elucidating and enlightening us on AI in cardiology. We have Dr. Ganesh with us, and Dr. Bali and Dr. Bahal will be joining in. So Dr. Ganesh is in Manipal, and is also working on AI in cardiology as a project. So I think we can have great inputs from him as well. And over to you, Dr. Parale, sir. Let's hear from about AI in cardiology from you. Thank you.
Thank you. Okay. Uh, although this topic is a broad AI in cardiology, my main focus will be AI in ECG. What is AI? Just brief introduction. As you know, it is any system capable of simulating human intelligence and thought process is said to have artificial intelligence. That Turing is credited to be he's believed to be a father of AI because he was the first one who broke the code during Second World War, of German code, which was uh, the first working electromechanical computer. Now, till today, it was considered to be to qualify a machine to be artificially intelligent. It was said to be a Turing test. If Turing test was positive, then it was considered to be artificially intelligent. According to Turing test, if human is interacting with another human or machine, and if he is not able to distinguish whether on the other side there is a human or machine, then the machine is considered to be intelligent. This was the definition till recently, but now this definition no longer holds true because with ChatGPT coming in, we know ChatGPT qualifies this criteria, and we don't know whether the response given by ChatGPT is given by a machine or human. But still, it is not fully intelligent, as we will see later. Then why there is sudden AI boom today? This is Moore's law. The Moore's law stated that the computer power will double every 12 to 24 months. And as you will see here, from 1900, the computer power has nearly increased 20 times increase in speed because of the changes in the configuration, changes in the processing. So the computers are more faster, more accurate. And that's why they can use more data and give the solutions early. Now, how much is the data that is annually generated? This is just for our general information. It is said that before 2010, whatever still from the humankind came into existence, whatever the data was generated till 2010, more than twice that data is generated after 2010, and it is growing exponentially. As you will see, this is in zettabytes. The zettabytes is 1000 terabytes. And that's the data which you are generating today. And most of the models, that is NLP models, natural language processing models like ChatGPT, they are using such a high volume data. Now, GPT-3, which has been launched, it is using 175 billion parameters to give the response. So such a high volume data is being used, and that's because of the current generation of computers that we have today. Now, what are the dimensions of intelligence? The intelligence has some physical dimensions and some mental dimensions. Physical dimensions like vision, audio, mobility. This, I doubt, the machines today will acquire in recent future. Now, some of this, all these mental dimensions, these present day machines or the models, they have been able to acquire, like recall, social reasoning, some common sense reasoning, natural language processing. So these are the ones the present ChatGPT and the similar models they have been able to adopt. So these are the things which is not there till today. This is not there till today. This is definitely common sense reasoning, natural language processing has come with ChatGPT. and some are doubtful. So that's the status of the AI today. Now, before going to AI and cardiology, we have to understand AI and biostatics is different. In biostatistics, we start with the hypothesis and then we prove the hypothesis. We have different variables and parameters and we try to find out the relation between them, like whether smoking is related to lung cancer. So we try to find out the relation. Unlike this, in AI, there is no hypothesis, but we give data to the machine and it finds out whether there is a common pattern. And with those patterns, it tries to make future predictions. So it involves training and learning. So this is different from the biostatistics. Now, there are so many applications of AI cardiology in ECG, echo, MRI, CT scan, and so on and so forth that I won't do. Now, coming to the AI in cardiology proper. Now, basically, three aspects of AI in cardiology are to be discussed. One is echocardiography, second is coronary angiography, and third is ECG. Out of these two, echo and coronary angiography, I'll just run them through because if we have to discuss everything, that is going to take a lot of time. Second, ECG, AI in ECG is more interesting. And third, AI in ECG is more close to my heart. So I'll just quickly touch upon echocardiography, AI and angiography, and then concentrate on AI and ECG. In echocardiography, as you know, now most of the today's machines, they have AI integrated. The EF calculation is automatic. The strain imaging is automatic. They measure the diastolic function, RV function. Most of them, the moment you give the view, particular view, it identifies that it's a four-chamber view. It identifies it's a mitral valve, and it automatically starts giving us measurements. So these are the different papers which have come out of AI in ECG, like for diastolic heart failure, left ventricular filling pressures, then for even detecting abnormal patterns in different images, wall motion abnormalities, LA thrombus, and so many things, identifying pacemakers. So many papers have come about AI in echo. I won't go into details of that. In fact, there has been this interesting paper where with echo, you can predict what's patient's sex, what's patient's age, what's patient weight, height, with reasonable accuracy. So these have been different papers which have come for AI and ECG. Then AI in coronary angiography, most of the data we have is from the Canada Montreal Center, where AI can localize stenosis, can predict their severity. It can identify which view it is, RAO, LO, which view it is, and it can finally, it can make an accurate prediction of what is the diagnosis. And this is very important because that's what a standardized diagnosis given by AI, and there won't be inter-observer variability. So here you can say you can detect what angulation it is. It can detect which vessel it is the left coronary. Then it can identify where the lesion is. And with nearly 89% accuracy, it can predict the coronary artery stenosis. So we are still not there, but yes, we are moving in that direction. Now, this is that the validation also, if you see the area under curve is around 80 to 85% with different lesions, but there is some disagreement amongst the amongst the cardiologists and the AI model. So we are not still there, but yes, we are going to reach there. Not only about the stenosis coronary angiography, but on coronary angiogram, the AI can tell you what is the ejection fraction of that patient. So, and it is, again, the area under curve is around 80 to 85%. With reasonable accuracy, with different views, AI can tell you what is the left ventricular ejection fraction. In fact, most of the data I told you is coming from the Montreal. Now, this is give an example. When this video was given to the AI, it said the probability of ejection fraction less than 40% was 98%, when the actual ejection fraction was 22%. So fair, accurate. Here, in fact, there is a lesion in LAD, but the AI said the probability of ejection fraction less than 40% is only 2%, and actual ejection fraction was 55%. So AI is fairly accurate. Even on coronary angiogram, probably it looks at the heart shadow here, the shadow which is here, the contraction of this shadow probably will be the basis for it to make the diagnosis. I have a collection of my angiograms over the last 25 years, or 30,000 CDs I already have. And with this data, I am having active collaboration with this Montreal Center. And my data is being used for the validation of this angiography AI algorithm development, especially for the stenosis. And we are going further to predict whether a particular, after the particular procedure, the angiographic characteristics can predict future restenosis. So that's the next step. So we have just started our collaboration. Now coming to the interesting topic of AI in ECG. Now, AI in ECG is different from a computer-generated interpretation, because in computer interpretation, you give a specific formula to the computer. Like suppose for left ventricular hypertrophy, you say SV1 plus RV6 more than 35 millimeters. So if it is there, it will say the LVH, otherwise it won't say LVH. But this is not in AI, because here you will see many times you have false positive and false negative. Many times a thin chest wall person has this formula which holds true, but he doesn't have LVH. Many times LVH is there on echo, but the ECG doesn't pick it up. Unlike this, what AI does, in AI, you give the ECGs of echo proven LVH to the model. So it itself finds out the pattern, and it itself finds out what pattern will suggest that there is LVH. So this is likely to be more accurate than what we see about the computer interpretation for the different parameters, as we will see later. Now, given this example, the computer is shown that if the ST elevation is more than 1 millimeter, then it will interpret it as infarction. But many times, it is false positive. ST, you can have early reproduction and many other things, it can be false positive. Unlike here, in AI, you give all proven STEMI cases to the algorithm, and then it itself identifies that pattern, and then it diagnoses as STEMI, not looking at only ST elevation. It might be looking at certain other hidden characteristics which are not visible to the naked eye, as we will see later. Now, how does AI look at it? Now, here we will see we do ECG interpretation by looking at these different waves, P, Q, R, S, T. So we have only 4 or 5 parameters with which we diagnose different ECG condition. Unlike this AI, each lead, there are 5,000 points. Minimum 5,000. Some machines, they have 10,000 points. So we have 5,000. Here, due to lack of space, I'm able to show only few points. But if you see, these rows are 5,000. So 12 leads, there are 60,000 minimum points. So AI looks at 60,000 points, unlike the 4 waves which we look at. So it has 60,000 points from which it makes its judgment, makes its interpretation. So it is likely to be more accurate than our crude interpretation of making it from these 4 waves. Now, certain papers, certain studies which have come out mostly from the Western literature. Now, AI ECG for detecting left ventricular dysfunction. Most of the data which I am presenting has come from Mayo Clinic. Now, here, first in LV dysfunction, here nearly 50,000 ECG echocardiograms were used for training. That means who had echocardiogram as well as ECG done. Such 50,000 patients, they were used for training of the model. When you train the model, usually 70% of the data used for training and 30% used for testing, and subsequently you validate it with some other group. So here 50,000 was used for training and testing, and then this was validated with some external validation. Now here you will see the area under curve is 93%. So with a very high accuracy, ECG alone can diagnose left ventricular dysfunction with a very high, as we will see from subsequent examples. Now, this is a patient. If we are given this ECG with lot of our experience and ask what is the left ventricular function, I doubt we'll be able to tell whether there is left ventricular dysfunction. Here, AI model said that it is positive for low ejection fraction, but actual ejection fraction was 50%. So that time it was labeled that this is probably false positive. But 5 years later, the same patient went on to have left ventricular dysfunction. His EF came down to 31%. So the question was raised, a postulation was raised, whether AI is able to see future, like astrology. It predicted what's going to happen. Whether is it true? So a concept of previvor, that means AI is able to see or predict what is going to happen. This patient is going to have left ventricular dysfunction in future. And this data has shown that probably yes. Now, when AI said that the patient has likelihood, initially patient has low EF, although ejection fraction may be normal at that time, these patients subsequently over next few years are more likely to develop left ventricular dysfunction than when AI says the left ventricular ejection is normal. So this is when AI says left ventricular ejection is normal, they are less likely to develop left ventricular dysfunction later than this group when the AI says that left ventricular dysfunction is present. Similarly, about the diastolic dysfunction, there has been a paper which shows that the diastolic function also can be diagnosed with fair degree of accuracy from ECG alone. Now, when we are given this ECG and asked whether these patients are left ventricular dysfunction or not, it is very difficult for us. What we might at the most look for is the LV forces, which are maybe borderline, maybe some P-terminal force, yes, but not very conclusive. But when AI model was given this ECG, it said that there is 76% probability of ejection fraction is less than 35%. And patients, this ECG ejection fraction was 18%. So it was very high accuracy with ECG alone. The AI is able to diagnose left ventricular dysfunction. Now, not only it can diagnose this at one point of time, but it has been shown that this algorithm is quite robust. Over a few months to years, that algorithm is robust enough, and it is true with time as well as different patient races. This algorithm holds true. Now, in fact, this paper in Lancet has shown that this ECG can be used as a biomarker. If you can integrate ECG with a stethoscope, in emergency room itself, when the doctor puts a stethoscope, he has a single lead ECG. With that ECG, they have developed an algorithm, and it can be detected whether the patient has left ventricular dysfunction with the stethoscope alone using ECG as a biomarker. In fact, this application is US FDA approved. So the places where they don't have facility of echo in peripheral centers, if this ECG, AI integrated ECG, stethoscope integrated ECG is given, maybe the triage can be done for the left ventricular dysfunction. Now it is also very interesting to see where the AI looks at, because I told you it looks at 60,000 points, but where is it? Now it is surprisingly that we looked for the left ventricular dysfunction at the LV forces or P-terminal force, but AI looks at only V3. This is a sensitivity map which tells you from where the AI is making its diagnosis. So here it looks at lead V3 only. Initially, it was thought that probably this position is responsible. So the lead format was changed and the leads were shuffled and the V3 was brought here. Again, the sensitivity map showed that it is looking at this. Again, this was a different format. This was a different format, but sensitivity map showed that it is looking at lead V3. So it is interesting. So we don't know, it is called as AI is a black box. How it makes its interpretation is not known. The sensitivity map may give us a clue that what exactly is wrong somewhere, which AI is looking at to make its predictions. Now, about this left ventricular dysfunction, there has been a clinical validation with this large study of over 22,000 patients in a clinical setting, in a peripheral center, where the clinicians, the group was divided, where the AI was given to one group and AI was not given to another group. It was shown that AI model, the diagnosis of low ejection fraction was high than who were not given. Only clinical based evaluation was done. So AI can again risk stratify even in a tertiary center with ECG alone. to say which patients have left ventricular dysfunction. Now, the second important application is to detect silent AF. As you know, the AF can have a disastrous complications, especially strokes. And once it occurs, then it is irreversible. So if we can predict a patient whether he is going to have AF later and preempt and start anticoagulation early, maybe these disastrous consequences can be prevented. Now consider this example. This is a 65-year-old female. She had first stroke in 2010. That time there was no AF and she was not anticoagulated. She had another stroke. Holter was done. She did not have AF. Then later on she presented with AF. Now this see the timeline. This patient, initially when AI algorithm was predicted, then at around 2015, the AI algorithm said that this patient is likely to have silent atrial fibrillation. That means intermittent atrial fibrillation. And in fact, this in 2020, there was overt atrial fibrillation. So AI predict if anticoagulations would have been started then perhaps this stroke in 2020 could have been prevented. Now, again, another example. Now, this patient in 2008, this was the ECG. When AI model was given this ECG, it said no silent AF. Of course, there is no AF, overt AF, sinus rhythm, some VPCs, but AI said no silent AF. Then 5 years later, again, this ECG is an absolutely normal sinus rhythm. But when AI model was presented this ECG, it said silent AF is present. We can't diagnose this AF with our naked eyes. And this patient, 6 years later, went on to develop overt AF. So again, a previewer concept. So AI was able to predict future occurrence of AF. Now, how is it possible? Probably, now some studies. Now, again, the data is from the Mayo studies. Again, they have data collection of more than 4.5 lakh ECGs and from around 1,26,000 patients. They testing was done 36,000 patients. And again, with a very high accuracy, area under curve 90%, they're able to pick up that silent AF, intermittent AF, when actually patient has sinus rhythm to diagnose underlying intermittent AF. That's what they did. Now, how is it possible? As we know, before AF actually develops, there has to be some structural changes like myocyte hypertrophy, fibrosis, chamber enlargement. And these changes probably AI is picking up with those 60,000 points. And to give you an example, many times during TE, we see that LA appendage is fibrillating, while the main chamber is not. So perhaps that little fibrillation in some part of the chamber that AI is able to pick up, which the full 12 lead, normal conventional 12 lead is not able to pick up. Again, the clinical validation has been done of this trial. Again, the Mayo group published in Lancet in a large trial, and they found that when AI picked up the ECG, they had higher chances over 9-month follow-up to develop AF than when AI said it's a low risk. Now, there are certain trials underway. In fact, there is a trial underway for prophylactic anticoagulation when AI says there is a high risk of intermittent atrial fibrillation. Now, another interesting AI ECG for detecting hypertrophic cardiomyopathy. As we know, around 10% of the patients have normal ECG of hypertrophic cardiomyopathy patient. They have normal ECG. If you have classical giant T inversions, of course, we know. But if the patient's ECG is normal, then still patient might be having hypertrophic cardiomyopathy, and that AI is able to diagnose. And again, the Mayo group has done it with a very high area under curve or 95% with a quite high accuracy is able to diagnose hypertrophic cardiomyopathy. Now, give you an interesting example. When we are given this ECG, I doubt how many of us will be able to diagnose hypertrophic cardiomyopathy on this ECG. However, AI model said there is 72.6% chance of having hypertrophic cardiomyopathy. Now, this patient was diagnosed with hypertrophic cardiomyopathy, underwent myectomy, and then again AI was given this ECG, where it said now the chances of HCM are only 2.5%. What we see here is some ST elevation, but again, we are not able to say whether it is HCM or no HCM. But see, with such a high accuracy, when it was there, it was able to diagnose, and when there is not there, it is also able to diagnose. Now, this is a 23-year-old female who comes with syncope. If we had given this ECG, what we will look? We'll look at whether it is Brugada, whether there is epsilon wave, what is the QT prolongation in a young female, and that sort of thing. And we'll label this as a normal ECG. However, when AI model was given, it said that it is likely to this patient has hypertrophic cardiomyopathy. So without any very hi-fi investigations, with simple ECG, you are able to get diagnosis of syncope. Not only AI is able to diagnose left ventricular hypertrophy or hypertrophic cardiomyopathy, AI is able to diagnose what type of left ventricular hypertrophy it is. As we say, it is rather than hypertrophy, what is the cause of left ventricular thickening? Whether it is hypertrophy, hypertrophic cardiomyopathy, hypertrophy because of aortic stenosis, hypertrophy because of hypertension, or it is just thickening because of amyloidosis. So AI with a very high accuracy is able to diagnose on ECG alone, not echo, or ECG alone, whether it is cardiac amyloidosis, whether it's hypertrophic cardiomyopathy, whether this is hypertrophy because of aortic stenosis, because of hypertension, or any other cause, just athlete's heart. So this is very important that AI is able to do it only with ECG. Now, very other interesting concept, the age. As we see, what we refer to as age is a chronological age from the date of a birth. But this age may not be the true age, because there is something called a vascular age also, or also called as a biological age, because certain things make you older, like social isolation, illness, obesity, diabetes, and variety of diseases. Now, it is believed that the AI can diagnose your vascular or biological age. And you'll see the algorithm with this linear regression, it is fairly correlating with the actual age of the patient in normal patients. In normal patients who don't have disease. Similarly, AI can detect gender with a very high accuracy. Now, again, this Mayo group, they developed a model to calculate ECG age. Initially, they calculated it with a normal patients with very high ECG data, with lakhs of patients. They developed a model where AI could be able to diagnose age, and then they applied to different groups. And when they found when the difference between the AI calculated age and patient's chronological age, if it is more than 7 years, then it is like they are likely to have more mortality. So the gap is more than 7 years. So this is the another different group. Same thing, if the gap is more, the ECG age is more than the chronological age, they are likely to have more mortality. Now, this is a very interesting example. Now, this is a lady who age was 35 years. Her weight was 106 kg and BMI was very high. AI said her age is 40.8, when actually her chronological age was 35 years. So the gap was 6 years. Over next few years, in fact, over next 1 year, she lost 10 kgs and her BMI came down to 36.2. From 106, her weight came down to 96. Now, even AI model was given her ECG, AI model said the age is 36. So though she became younger. So there was no age gap. For us, if you are given these two ECGs, they are identical. We will not be able to tell the difference between these two ECGs. But AI model was able to predict the age, which was more here when her weight was more, And then again, when the weight reduced, the AI model was able to say that, yes, the age gap has reduced. So this is very interesting. Now, this is another very interesting in talk by Dr. Friedman. I picked up the slide from his talk. This is a very interesting slide which he presented. Now, this was ECG. He said this is of the patient, this is a chronological age, and this is the ECG age. As you will see over the years, as the chronological age increased, the ECG age also increased proportionately till this point. Then suddenly the ECG age decreased. At this point of the time, he asked the audience what could be the reason. And he got funny answers. Some said he got married. Some said he got divorced. But what happened was he got heart transplant and he had younger man's heart. That's why his ECG age came down. So this is how important it is. So now what we are likely to have in future is these are computer generated information. And here perhaps we'll have a AI generated information that what is his AI age, means what is his biological age, what is his gender, what is his likely ejection fraction, whether he has silent AF, whether he has chances of having hypertrophic cardiomyopathy, so on and so forth. Similarly, AI is useful in diagnosing pulmonary hypertension. As you know, the conventional ECG has a very low sensitivity and specificity for diagnosis pulmonary hypertension, but AI has a very high area under curve for diagnosing pulmonary hypertension. Similarly, if AI says that patient has elevated pulmonary pressure, then they are likely to have more cardiovascular mortality as well as more all-cause mortality also. Similarly, aortic stenosis critical, and there are so many other papers looking at different aspects for ECG alone for making different diagnosis. Now, this is another interesting, they reconstructed full ECG from 3 leads. Only 3 leads were used. 3 leads, 1, 2, V3, and 12 leads were reconstructed, and this with which you could make various ECG diagnoses. Now, certain non-cardiac conditions also could be diagnosed. There have been different papers where certain these non-cardiac conditions also were able to be diagnosed. Now, there are challenges and limitations. I won't go into details. Only one interesting example I'll give you, because the data is very important. Not only the quantity of the data is important, the quality of the data is also very important. That's what I would like to emphasize by giving you this example. Now, if you see this ECG, in fact, this ECG is overlap of 2 ECGs. One is in the blue color and other is in the red color. Only when we magnify this point, then we are able to see that there are 2 curves, not a single curve. Now, there is a blue curve. When the blue curve ECG was given to the AI, it said that this patient is likely to be male. But when the red curve was given to the AI, it said it's likely to be female. For us, it is same ECG. You got my point. It's same ECG. We are not able, human eye is not able to differentiate, but that little noise there is totally make a different diagnosis. So not only the quality of the data, quantity of the data, the quality of the data is also very important. Now, this is certain these applications which have been FDA approved. So these are different a priori. I won't go into details. Now, as you'll see, the most of the data here is come from Mayo Clinic, and most of the papers have come from the Mayo Clinic because they have a very large data. As you will see, there is no Indian data so far. Maybe Dr. Ganesh will come up with Indian data later. So why there is no Indian data? Because we have to have a large data in EMR. We have to have a long follow-up, and we have to ECG in binary. That raw digital ECGs have to be there. Then only you can have a proper accurate. Of course, with the PDF, you can have AI application generation, but that may not be as accurate unless if the ECGs are in the digital format. So I decided to take a baby step in AI ECG because I have EMR data of over 60,000 patients over last 12 years. I have over 1.8 lakh digital ECGs, and there is at least one ECG per patient. All the ECG data is in the digital format. I have a clinical diagnosis of all these patients in more than 95% patients. I have echo report in more than 90% of patients, and I have other data of them in over 95% patients. So I started small. I started with my little, of course, I didn't use my full data, maybe only around 1,000 patients that I used, and said whether I can diagnose gender of the patient. And yes, with a very high precision, 85% and area under curve 93%, I was able to diagnose the exact gender of the patient with ECG. Then I went further, said whether I could be able to diagnose the age. Again, with the accuracy of 92.17%, I was able to correctly predict the age of the patient. Then I decided to go further. The study which has not been done so far in the literature, I didn't come across any study in the literature, because as we know, in left bundle branch block could be because of the underlying structural problem, or it may not be underlying structural problem. So I thought whether the AI ECG is able to diagnose whether this LBB is because of the underlying structural heart disease, or whether it is just an innocent LBBB. I had around 317 patients of LBBB who had undergone echo as well as angiography from my over 55,000 patients. Then 117 patients had obstructive CAD, 97 patients had LV dysfunction with normal coronary angiogram, and 103 patients did not have any heart disease. So I developed an AI model, and this is a paper which I present here recently in APHR Sydney, where I was able to diagnose with a very high accuracy. Around the area under curve was around 83%. With ECG, I was able to tell whether the patient has underlying structural heart disease or not. This is around 83%. Then I went further about atrial fibrillation, because now for us it is different. The Western population deals mainly with the non-rheumatic AF. We have to have a rheumatic AF as major chunk of our population. So I had total around 1100 ECGs who had documented AF, but it was intermittent. Most of the time they had sinus ECGs, but intermittently they had atrial fibrillation. Such I had around 1,108 ECGs, 439 ECGs were rheumatic, 616 were non-rheumatic, and I had around 4,610 normal ECGs. Means these patients did not have any underlying problem, no diabetes, no hypertension, no heart disease, their cholesterol was normal, and echo was normal. So I developed a model, a classification model on these two groups. And I validated this model after training the model. I validated on this valvular heart disease, mean the patients who are having valvular heart disease, but ECG is showing sinus rhythm. Then those who are having obstructive coronary artery disease, but the ECG is sinus. Those who have diabetes with normal ECG, hypertension with normal ECG, and who have hypertension and diabetes with normal ECG, so many numbers. And this was in valvular heart disease. You will see the area under curve is 89%. In valvular heart disease, you're able to, in 89%, they are likely to develop AF sometime. So here, even if they're in sinus rhythm, if this validation holds true, maybe we can start anticoagulation before and prevent stroke later. Similarly, in obstructive coronary artery disease, the area under curve was 84%. In only hypertensive, area under curve was 66%. In only diabetes, area under curve was 57%. With diabetes and hypertension, the area under curve was 69%. So, of course, I'm still refining this model further, making still it better by training it further, and see whether I can come with better data. And this is this I presented again at the API Sydney this year. Now, one thing I find is, as we all know, the golden hour in myocardial infarction. Many of our patients, they don't arrive in golden hour because they don't have ECG done in golden hour, mainly because they are either remote place where the ECG is not available, or they in metros because of the traffic issues, they don't reach the center where the ECG is done. So I thought if the patient is able to record a ECG at his home, so you just like a BP apparatus, if the patient has a patch, 6-lead patch, he just applied it to our chest. And then if we are able to reconstruct 12 leads from those 6 leads, whether it is possible. So basically, if you apply it on the chest in the designated position, the anterior infarction will be diagnosed. But the diagnosis in inferior leads, the inferior infarction, that is a challenge, because to diagnose inferior infarction from chest leads would be a challenge. So I developed a model using my data, and here we are able to say that with fair accuracy, of course, we need more data. With but fair accuracy, I was able to reconstruct 12 leads from 6 leads. You will see here, this is the patients of infarction. The original ECG, 12 lead ECG is in red, and my reconstructed ECG from 6 lead is in blue. So this inferior infarction is not missed. Yes, it is not exactly same, but it is not missed. With further more data, further refinement of model, perhaps we can reach there. So this is all. Now these are the further projects which I intend to take, like biological age determination, diagnosing obstetric coronary disease with the ECG alone, detecting LV dysfunction, then to converting the PDF ECG into digital ECG, because most of the places they don't have digital ECGs. Then to diagnose the other conditions, and to diagnose 12 lead ECG from 6 or lesser number of leads. Thank you.
Well, thank you, sir. And I must say, uh, it's a mind-blowing presentation, at least for us. And the way you have said, so before, there are so many things that you said. Actually, I'm just overwhelmed. And maybe the Bali sir is here, Smith sir is also here.
Yeah, I got hooked. I could not leave. My
Thank
wife
you.
is
Thank you,
fuming.
sir. I thought you are an international match and we are going to ignore this topic.
No, my wife is fuming. We are late for the party anyway. There are two things. I think you have concentrated more on ECG, and
Yes.
you have done a very good work, sir. How do you get your digital ECG transferred to your PC? Because when I started my practice, I was after every company to give me a digital ECG that could transfer it to my PC.
Hmm.
And the cost that the G machine was, well, they're asking something around 4 5 lakhs extra for this compatibility.
Yes. Now, in fact, we have ECG GE machines. I purchased 4 machines and they give this software for free.
Okay. Because I approached G
Hmm.
and they told me that, I need to buy that all those things separately, the connection and all those things. And they at that time, 2013, it was costing, or rather 2004 5, it was costing around 4 5 lakhs extra.
Yeah, but most of my data, which I have presented, is from that indigenous machine, RMS company from Chandigarh.
Mhm.
They have digital ECGs. They give
So
this. That's
I
for free.
also
That's free.
acquired, I was not very sure. I also acquired one company called uh, uh, it is TriStar or something, which is a Pune based company.
Hmm.
So they had given me it's only an amplifier kind of thing, which previous tube lights had that square thing.
Hmm.
It is like a box, and it has to be connected to a laptop or a computer. Then only it will generate ECG.
Yes, yes. This RMS also, it is through computer only, but you have digital ECG for free there, and that machine is also
That
cheap,
is very cheap also.
50,000.
My
Yes, 50,000.
ECG machine costed 18,000.
Yeah,
This
yeah,
one, but I
yeah.
was not sure that whether I can it will be accurate or not.
Hmm.
Sir, what is this binary format? How do we collect that
That's what
binary?
we are talking. That is in numbers, which I showed
Okay,
you
okay, sorry.
my slide. Those numbers. So
So
raw data ECG. Actually, all
I'll
the questions they have raw data in the numbers, which is converted into the curves, the
Hmm.
ECG waveforms.
Okay.
All the
It is
current
actually,
ECG machines, they have raw digital data.
so for every curve which is going up, you will say it would be zero. Coming down will be one.
No, no, no.
And
These are
no,
numbers. No numbers.
yeah, that is I
That,
agree, sir. Just to make it easy for Sajatya,
yes,
this
sir.
is
So
how
like it is like on y axis and x axis sort of
No. It's in
vectorial
Excel form.
numbers.
Excel form. I showed you
Okay.
that. Can I share my screen again?
Yes, sir.
You can see this, my screen.
Yes, sir. It's the last slide. Yes.
Yes, last slide. Somehow it's not going up.
While you are showing, sir, there is one course on machine learning from IIT Kanpur.
In fact,
Which,
some of the algorithms which I have developed are with some engineers from IIT Kanpur.
so I was about to join, but then last year was my daughter's PMT time. So this year I plan to join that.
So somehow I'm not able to change my slides.
Sir, so suppose we want to, like,
So,
we all have.
to give an example, each lead is 5,000 points.
Okay.
And so 12 leads is 60,000 points. That is my machine. GE machine, each lead is 10,000 points. So they have 1,20,000 points to analyze.
Sir, so how can we contribute? Suppose, like, from our end, if we want to send data to you, so what is the format, or is there any, what are the
No,
minimum
that's now
requirements?
this is what I want to show you. Now, can you see this slide? So these
Yes,
are
sir.
the points.
It's visible.
These are the digital. This is the raw data which the machine is, which is converted into the various waveforms by the algorithm. So this is the raw data. This is here I only showed 35 columns, 35 rows, but it is actually 5,000 rows plus per lead. This is what is a binary format.
Okay.
Yeah. And sir, there is Indian data also available, because just 3-4 days back, I was helping one of my colleague's son who is into AI. He's an engineer. And he had shown me a paper by a South Indian doctor which was interpreting EEG into 4 moods: happy, sad, angry. That study was, I think, 2017 or 18 study, and this boy was trying to replicate that.
Okay.
So beyond ECG, sir, there are like electrophysiology mapping.
Yes.
That is also AI based. So that
Many
is
EP
how
also. Yes.
calculate.
EP. Yeah, there have been applications in electrophysiology also. This is
There
going
is
to be
one
future. In fact, I have
you
enrolled
can
for a.
judge whether at discharge the patient is. So at discharge, the patient is asked to speak, and record his voice, and from the voice recording, they can predict that this patient would have a readmission with heart failure in the next 1 month.
Yes.
Dr. Bali,
Then finally, if you have
Dr. Parley, can you hear me?
witnessed Ultron software.
Yes.
I think one of the most mesmerizing talk I have heard for a very long period of time, and Parley, you have done a wonderful job. And I must say, I'm really, really proud of you. Two points which I'd like to make. One is when we talk about left ventricle, you talked about left ventricle ejection fraction being 50%, and the ECG recording it as normal, and over a period of time, it developing into left ventricle dysfunction.
Yes.
Now, there is a concept of normalcy. So normalcy, when we speak about, we have a range, means whatever plus minus 2 standard deviation.
Yes.
So in a given patient, we don't know what is the normalcy for that given particular patient. So for example, we know when we were doing mitral stenosis a long period of time, about 20 years back, in mitral stenosis, you will have a cardiac output of 2 or 2.2, which would be normal in that given patient, and we would say it is normal. But you do a balloon mitral valvotomy and you find out the cardiac output goes up. And so therefore, we don't know. Similarly, when we're doing aortic stenosis or something like that, and we know that this is the normal ejection fraction, 55% above is the normal ejection fraction. Well, that is the normal ejection fraction for a group of patients.
Yes.
That given one patient may have been 65, from where 65 it has fallen down to 55%, and we are still recognizing it as normal.
Yes.
When your ECG at that time is showing an ejection fraction of 50%, would not be normal for that particular patient. So it's likely that it is correctly diagnosing a left ventricular dysfunction at that particular time also, which clinically for us is not within the normal.
It's normal, yes. That is, yes. Perhaps that AI is diagnosing it before It is
Before,
clinically apparent.
because it is not falling in our range.
It is not falling in our
But
range.
actually, for that particular given patient, it is left ventricular dysfunction.
Right. Yes.
Right? So that is
Yes.
one point. Second thing is when we are predicting a particular thing, this AI is predicting at that given moment in time.
Yes.
Means, as you said, atrial fibrillation would develop in a given person because of these parameters. And then subsequently, supposing it is predicting that there's a 70% probability of developing an atrial fibrillation. Now, there is a milieu, cardiac milieu, or an entire body's milieu, which will be determining that ECG at that given moment in time.
Right.
Now, over a period of time, that milieu could change.
Right.
It could change on its own. It could deteriorate. It could improve, or it could remain stable, or the additional factor may come in.
Right.
So you will have to have a sequential thing to find out whether that milieu, this is at that moment, over a period of time, how it will develop. Would it
Yes.
develop over a period of 5 years, 7 years, or maybe it may change. He
Yes.
may, over a period of time, he loses weight, he becomes non-diabetic, he leaves cigarette smoking, that ECG may show changes. So
Yes. Right.
that is the second part which may happen. So at this moment, AI is only picking up at one given moment in time.
Yes.
Right?
Yes.
So that is the second part of the story. The third part of the story is when this happened in CT scan and MRI when they came initially. Now all the trials which we have done, all the data which is available, is for those people where we have a clinical diagnosis. And then we try a particular intervention and drug and show over a period of time that will have a mortality benefit or whatever MACE benefit or not. Now, when you are detecting something so subclinical that we don't know over a period of time what would be the impact of an intervention. And if you remember in MRI, this was called as the accidentalomas. Now you're detecting a lesion which you are not sure about what is the implication of that over a period of time. And should you be treating them or not treating them? Okay. So therefore, from one given ECG or a group of ECG, which shows that the predictive value of him developing a left ventricular dysfunction is so much, we would need an entire new generation of trials to say
Yes.
that intervening at this level with this particular drug or an intervention would have a positive impact or would not have a positive impact. What we
Yes.
talk about NNT and
Yes.
how many we would be requiring to treat those patients and
Yes.
whether that would be beneficial or not. So those
Yes.
are the things which I want you to respond.
Yes, absolutely right. That actually AF trial is underway, Beagle's trial is underway, where the anticoagulation in a silent AF, whether it will be beneficial. That trial is underway.
No, but we know that if you have, supposing atrial fibrillation in an 85-year-old patient, or you have a atrial fibrillation which is with multiple risk factors or something. So it is not necessary that the anticoagulation may be beneficial. The hemorrhagic side effects of anticoagulation may outweigh the benefit of preventing a stroke in such a patient. So we would need the entire, means all of our trials would become relevant. And then you also made a statement that, insurance companies can decide it and whether the chronological age is different.
Biologically, yes.
That is opening up an entire different Frankenstein
Yes. That is going to have tremendous repercussions.
theory to even look at that. So we are in an era where we would be diagnosing a far more diseases, a far more problem than we know whether treating those with the available resources we have or available intervention drugs we have would make the same impact which it has done in the trials where clinical diagnosis was the entry point.
Yes. In fact, one of the insurance companies came to know that I'm working in AI in ECG. They contacted me and asked me whether I can predict age from the PDF. I said, I have not developed a model so far. In fact, they contacted me. This is
So for beginners, how do we, if suppose we are interested in...
basically why I wanted to give this talk is because, see, Mayo Clinic can generate 4 lakh ECGs. India with so much population, we have so many centers of excellence. Why can't we collaborate and generate data? Our data will have such a volume of data. That's my basic condition. We have to have collaboration. We have more volume than them. Simple ECG. We can generate
Yes.
more qualitatively and quantitatively data than them. We can come out with better algorithms suited to our population, like rheumatic populations. We have to come together. This was my basic intention of basically giving this talk, because that's why I wanted someone from PGI there.
Sir,
So
we can actually send data over to you if you can specify some format or areas where we
now
can
once
send like
I'm
ECG with
able to develop a model of converting PDF into digital ECGs, maybe because your all ECGs will be in PDF format.
mostly in PDF. Yes.
Yes. In fact, Narayana Rudayala also is working, but they are also working in PDF format. PDF is not as accurate as a digital raw data. So
Okay.
ideally,
Sir,
you have to have a raw data.
if you allow me, why don't we propose that for PGI, we can have a digital ECG? It's not costly.
It's not costly.
Now that the TriStar company, I'm forgetting the name. It's a
No, but
Pune-based company.
with RMS,
I
you can go with
bought the
RMS. RMS ECGs I'm
uh,
using for 20 years. So
that machine costed me only 18,000. And therefore, because it was so cheap that I was, not confident that whether the readings would be accurate or what. We can validate that machine, and many of us can use those machines, and we can generate ECGs
But how
rather
do we
than
collect all
converting
those
PDF
ECGs?
PDF to and having inaccurate data and a limitation that we have converted PDF to. PDF is again analog, and then you are unnecessarily digitalizing it.
yes,
So
that's
that there would be too many things lost in translation.
agreed.
So
Yes, but
why
with the
don't
ECG,
But because most of the places they don't have raw ECG. That's why
sir, sir,
something next base.
if
That's
if
all.
if we make it like a project, we can pick a few centers, those who are interested, and PGI Cardiology alumni can finance those ECG machines and data collection.
and we can send over the data actually to you or for
I
analysis
think
and for
Saujatya, it would be better that we start generating data. Sending
yes.
is okay.
So
Analyzing
what
is
will be the
also okay.
format?
Analyzing
There
is
must be a,
nothing. It's computer based.
so along with ECG, we'll need clinical diagnosis. We'll need some
Yes,
imaging.
labeling of the data
Yes,
is important.
yes.
Labeling of data is very important. How many are diabetic, hypertension, their age, sex, weight, as much information as we have, because that will, the multiple parameters is going to improve the model. Today we are making predictions, as Dr. Bali said that AF prediction we are basing only on ECG. But now if we add the risk factors to it, diabetes, hypertension, age, perhaps that model will be more accurate, more robust. So if more the parameters we have, the better the accuracy is going to improve.
Right, sir.
So I can have it at my center, sir.
Sure. Start
And
generating.
we do almost 100 ECG a day.
Yes. See, I think GE company will give you. Why go? GE company will give you the software. I got it for free.
Right.
So let me find out, sir. Otherwise, from I can generate finances for taking up this as a project, and we can go ahead, sir.
Yes. What I need today is a good data science support team. Presently, with some contacts, I am able to develop this algorithm, but it's not a permanent thing. In their leisure
So,
time, I just request them. I am after them, call them every 5 days, 7 days, and then they
sir,
develop algorithm. If I have a permanent data science team, if I can finance it, perhaps we'll have more and more
okay,
different predictions,
sir.
different
There
projects.
two to three things that I have a research fellow. One, secondly, I am also trained in R software and Python. So there, part of it I can help with, and rest of
But
the
we
things
need
I'm
really someone who is a data scientist. See, we have to
yeah.
generate a real, very high accurate data. So we need a qualified data
So
scientist. So
yeah. So at my
We
center,
have,
sir, today
if
on.
you have, doctor, anyone has a, maybe
Dr.
some
Parle,
IIT
Dr.
person,
Dr. Parle, my daughter is doing a AI PhD in Carnegie Mellon, and
okay,
she's into human-computer interaction, and she's
okay,
looking into medical aspect. And I think
then,
when she's here in the first week of December, I'll have her talk to you.
okay,
She's
yes,
also
that would
looking
be
at
very
how to
nice.
go about this data.
Yes, yes,
That
yes.
is one just her area of doing. I think that's a very expanding area, and it will be great to have you talk to her also.
Yes,
See
sure.
how
Because I've been talking to different people, but I'm not getting a
she can
permanent
give the
support.
technical part of it. So
Yes, yes, yes.
Ganesh, how are you collecting data?
Yeah, yeah, I wanted to just pitch in, but a lot of interesting discussions happening, so I thought I'll just listen in first before I make my comments. Sir, first of all, great talk. You put together a wonderful presentation, and you have given us the breadth of what is happening in AI and ECG, and also touched upon other areas in cardiology. It was a very engaging presentation, and Bali sir or Smit sir also vouch for the same thing. And it's I would say that we are currently in a very exploratory era of AI in healthcare. So this is where all the translation has to happen, and we'll see like real groundbreaking changes possibly in the next 5 to 10 years or so. And people like us have to be involved in this kind of research, and it's great to see you. You already have a great start. Personally, I haven't started it with the ECG per se. I'm still working with CT coronary angio, some echo based data, and I'm working on some non-cardiac projects also. Uh, I actually have made a couple of teams to work on ECG data, and it'd be great to collaborate with you too. I'm just completing my data science and AI applications degree from IIT Madras with a good CGPA of around 9.7. I'm also interested in coding. The problem is time is a bottleneck. So I'll definitely be able to put together teams to work on this. Yeah, the most important point that needs to be discussed is the data. Like you rightly mentioned, most of the studies come from Mayo Clinic because from 1970s or so, they have an extensive collection of very good quality labeled ECG data, both in digital format and in the image-based format of PDF or JPEG format. And they have high quality labeled data. Now that is something that is very, very, very important to understand. So if I can go a little deeper, AI algorithms, deep learning, machine learning, all these are part of the general umbrella term called AI. And machine learning and deep learning are the key tools which we use currently to build all these classification models. A classification model is one which will take in data and give you an answer, which is yes or no, or as if, choose from a list of categories that you would have trained it on. The most important distinction I would want to make is the broad groups that are there in AI based projects is unsupervised and supervised learning. So in unsupervised, I'll come to supervised learning first. Most of the projects that happen is using something called as a supervised learning, where you will have a lot of data and labels to go along with it. By label, I mean you have, let's say, 100 different data points, or let's say raw ECG data, and then there will be an answer at the end of it that this ECG means there is HCM. This ECG means there is LVH. So you need these high quality label data set. Or when you want to predict EF, you would want, let's say, few thousand ECGs, and each of those ECGs should have an EF number corresponding to them so that you can build a model. So this kind of label data is the key to building high quality models for classifying. This paradigm is called the supervised learning. Unsupervised learning is where you don't have such labels and you try to find predominantly it's used for clustering and what we call dimensionality reduction, but that doesn't have as much applications. If we are able to generate supervised data for supervised learning, that would be great. And already, like Smith sir and you were discussing, collecting good quality data along with proper labels, like you mentioned, sir, is very important. Possibly, we can start collecting right now on digital format or PDF, whatever is available, and we build a database with good labels. So every ECG should have a particular number or something assigned to it, and it should have a corresponding set of labels. A label can be anything from age, gender, EF. It's better to build a basic set of labels. Sir had already presented so many different papers, and each paper, whatever they're trying to predict, can be a different data point that we collect, like age, gender, LVEF or HCM, LVH, AF, subclinical AF, and all those things put to the labels which you can connect. So that said, I'll just talk briefly about the two kinds of ECGs that we are already discussing, that is the raw signals and ECG images. So there are two general these are the basic two main types of approaches that we have to have for ECGs. Raw ECG signals would be the best, like sir already discussed. But then in real world, over the period of years, we have accumulated so much of images and PDF data that it's hard to ignore. And there are approaches to build AI models using them also. So for those models which require data signal, you need a different set of AI models, possibly RNNs, recurrent neural networks and their variants. Whereas for image-based models, you'd require what is known as convolutional neural networks. And like sir rightly pointed out, image-based ones are usually inferior because not because the model per se, but it's because of the lack of consistency between ECG images. Even things like crumpling or some kind of ink marks or not proper cropping, non-standard angles, all these can affect the image-based models, whereas these problems don't exist with a raw ECG data. So going forward to build really great this thing, if the world changes to raw ECG signals totally, it would be a very welcome change. But unfortunately, we are not there yet. And already there are like thousands and thousands of ECG machines out there producing image-based. So both approaches probably would need to be taken. And like already discussed, it's a complete black box. Many a times we don't know how it is diagnosing, what it is diagnosing. For that, there are few techniques collectively known as explainable AI. In one of the slides, Parlisa showed us how the that ECG, he showed us the heat map kind of thing where you see different shades of color and you show that it's focusing on lead 3. So those are known as explainable AI techniques, because if you give a let's say ECG to an AI machine and then it spits out a diagnosis, and then you give that diagnosis to a doctor or a cardiologist or even a patient for that matter, they will hesitate to accept it, because we as humans always seek reason, explanation for why it is saying what it is saying. So this is a very, very big area of concern, especially in healthcare, where we need clear explanations as to why it has come to this conclusion, and not merely a single answer yes or no or LVH or EF number. So build alongside building these models, even explainable AI techniques are also taking catching up, and a lot of work is going on in that field also. And there are every day there is new architectures coming up. The public's eye was caught by ChatGPT, which is based on an entirely new architecture put forth in 2017 by a famous paper, Attention is All You Need, by the Google team. So that's called the transformer architecture. Now that is again going to be used for image-based ECG classification, and that variants of those can be used for raw ECGs also. So the field is rapidly exploding in terms of the architectures that are coming up, explainable techniques that are coming up, the number of clinical problems being addressed. So this is why I would say that this is a complete era of exploration, and there's a lot of exciting times coming up, and definitely worth investing time in learning what is AI and how it can be applied. And yeah, this is about the positive aspects. So it won't be correct if we don't discuss the drawbacks or shortcomings of AI also. Like Bali sir rightly pointed out, there are so many concerns that need to be addressed. So a good clinical question which needs to be addressed is probably the best starting point for AI-based solutions. We need to clearly define as to what we need to answer. For example, the same discussion on atrial fibrillation, subclinical atrial fibrillation that I was discussing about. So it's not just a problem that AI is. It's not. Let's not call it a problem. It's not just that the AI is picking up something with subclinical AF. There is going to be a debate on whether it is correctly picking that up, whether it's correctly predicting subclinical AF for LA dysfunction or not, or clot forming tendency or not. That is one debate. The second debate is that AF itself, subclinical AF in clinical parlance itself, for example, device detected AF, or AF which doesn't last for much time, which is detected on a Holter. We still are exploring the clinical importance of these entities. So when we build these AI models, we need to make sure that at least clinically we have a very clear understanding on what we are trying to get to using AI solutions, because AI can be quite powerful, but still the lack of explainability still makes it very difficult to put it into practice. And a small example would be that a team built a model for classifying pneumonia in one of the, I think in one of the editorial comments or something. So what they did was basically they had a big data collection from one of the hospitals, basically from two hospitals, where they had group A, which had no pneumonia from one hospital, and group B, which had pneumonia from another hospital. They mixed this data up, and then when I say no pneumonia, what I mean is 80% of the cases from hospital A were normal and 20% were pneumonia, and whereas it was the other way around in the hospital B. So when this data was put together and a machine learning model is trained on this, what it actually trained on, it's an image-based classifier. What it actually kind of trained on is some kind of a data, which is some kind of a marker which is placed on corners of the X-ray, which identifies the hospital, rather than picking up lung areas for pneumonia. Now, that is how powerful the AI models are, that it will pick some kind of a pattern that is there on whatever we give it. But we need to be careful on whether it is looking exactly at the point that you want to look at or not. The same example goes in pathology slide AI also. Basically, when models are built on pathology slides, which were
Yeah, it was seeing the ruler.
yes, exactly. So ruler
Bottom of
stain
the, I think that went
differences.
very famous. Yeah,
Yes.
it was very famous on
So
Twitter.
right.
That
So
example you're taking.
yes. So basically they built these models on one set of the Western community processes the histology slides in a very different automatized way compared to the Indian community. When we tried to, one of the groups in Manipal itself, when they tried to directly use the models built by the Western on our pathology slides, they found that it doesn't work, nowhere near the accuracy that it is producing on the Western slides. And one of the key reasons they found was the variations in the colors of the slides, because the stain is not inconsistent, because we do it manually. Some are blotched, some are very colorful, some are very pale. So they built an additional model which kind of overcame some of these aspects and adjusted for the stain color, stain normalization, and they use several interesting techniques which I won't go into the details of. But what they did was they developed another model which was very accurate on our data. And when it was used on the the Western data, it did better than what the Western model did on our data. So in a sense, our model is more robust, but still it is not robust enough. to be put to production or released internationally. So these are some of the caveats. It's a very, very, very big topic, and I don't think I'll be able to cover the entire thing. I just finished by making one more important point, which is again something very similar to what Bali sir was trying to discuss. So diagnosing something right now versus predicting something in the future, using any technique for that matter, AI or not, are totally different ball games. Simply for the fact that a lot of things change between now and the future, many of which is not under our control. And first thing is whether this prediction can happen on the currently given data needs to be looked into very, 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 very carefully before we try to build models for future predictions. I'm talking about predictions. Diagnosing something which is there right now is definitely something which you can easily verify and easily control, and that is definitely a yes. But prediction, whenever we build something for predicting anything in the future, our most famous example is just predicting heart attack. We know where we are even after decades of research. We have physiology based, we have anatomy based, imaging based, intravascular imaging, biomarker based, inflammation based. Even molecular imaging, nuclear tags are there right now to actually try to predict MI, but we are nowhere clear. So when we are trying to predict future, we need to be extremely careful, especially when it comes to AI, because AI model will tell us some answer. It is when you build a classification model, it will pick one of the choices. So we need to be very careful when we do prediction models. Diagnosing models, on the other hand, is something we should probably start exploring because it's more of it's more under our control. Yes.
Thank you so much, Ganesh, and thank you so much, Dr. Parale sir. And like you said, I think we should move forward and try to work together. So there are lots of things going on, but I think the first step is to collaborate and start collecting data and know how to collect data and send it over to somebody who can analyze this data and use that data correctly. So,
So I'll be putting together, I've already put together few teams for even the ECG part, including members from Indian Institute of Science, Bangalore, and there are independent companies, members of independent companies, and also from MIT Manipal. But because of lack of time, I've not been able to move on ECG projects, but probably early 2025, I can make a solid move on that. So we're trying to enter these global competitions first. There is usually an annual challenge on ECG model building, both for the image-based and the raw ECG-based data. So that is something we're targeting next year. Alongside, it would be great to collect data, and then for our own Indian data, we should be able to build robust models.
So, Parale sir, would you like to say some concluding remarks, like how do we go about this, or what should be our vision, and how should we contribute to this AI revolution in cardiology?
It is data. Whether data has to be collected, it has to be properly stored, and it has to be properly labeled. And this data will be in any form, maybe your angiogram data, maybe your echo data, maybe ECG data, or just a clinical data. It is so basically we should start it from today. Data. So you have to have EMR and with proper labeling, so that you can extract that data in whichever form you want and whenever you want. So I think it's data, and of course, a single center collecting data will not be able to generate a good algorithm. But if multiple centers come together, perhaps we'll have a better algorithm.
Thank you, sir. Thank you, sir. So I think with that, if with your permission, we had a vibrant and wonderful discussion, and it's already 9:40 now, and I think we can keep on going discussing about it. But with your permission, sir, now I think we can end this meeting.
Yeah.
Thank you so much, sir, for that talk.
Thank
And
you.
thank you, everybody, sir.
Thank you,
Thank you, Bali, sir.
sir.
Thank
Thank you
you,
for the
Ganesh.
presentation. Thank you, sir.
Thank you, Dr.
Thank you, sir.
Good night. Goodbye, sir.
Good
Good
night.
night.
Good night.
Good night.